This next slide is really geared towards classroom conversation, but I want you to look at this and just tell me all the things that you see wrong with this patient. You see a patient who's intubated. He appears to be sedated. Hopefully he is. But look at the ET tube and imagine what that's doing to his trachea. Look at where the fluid's going to go as he exhales. Condensation is going to happen in that ET tube. Where's it going to go? Look at just how it's pulling on his mouth and just completely uncomfortable. So those are things that we talk about with patient comfort, not just vent settings, but actually taking care of our patient while we're at the bedside. From there, chapter 6 starts talking about initial vent settings. It talks about volume control, pressure control, and we've talked about these before. So with volume control, you have a set volume. You will have increased pressures and overinflation, more chance of volutrauma and barotrauma. And that's because the flow waveforms are square, not comfortable. The next slide talks about pressure control, the decelerating or the descending flow waveform. The lungs fill up more evenly. You get more mean airway pressure with less PIP, but the tidal volume will vary. So you do have to pay attention to that. But you'd have to pay attention just if you're in volume control as well. PEEP we use to improve oxygenation. Always use at least 2 to 5 because that's what we all have. And when we put the ET tube through the vocal cords, we lose that anatomical PEEP. So make sure you have that on there. And the next slide talks about pressure control. We can set the pressures at 10 to 15 centimeters of water pressure, or you can use what your plateau pressure was in volume control. Another thing specifically that I want to talk about with this section of YouTube videos is pressure support. Always remember that pressure support is to overcome work of breathing. If you were breathing through a coffee stirrer, you'd have an increased work of breathing. And that pressure support gives you a little bit of oomph. It gives you some extra pressure to fill your lungs without having to work so hard. So again, it is to decrease work of breathing. All patients who are in a spontaneous mode in the vent should have pressure support because they just can't pull through that ET tube. It would tire them out too much. So what I mean by that is there's a mode on the ventilator called pressure support. And we use that with CPAP. So yes, we can have somebody intubated and on CPAP. They're just getting positive pressure. They're just getting PEEP. And then we add pressure support to that. So it's like BiPAP on an intubated patient. And we can show you that in the lab. How to figure out where to set your pressure support. You take your peak managed plateau flow. And guess what? That's the formula for raw. So pressure support overcomes the airway resistance of the ET tube. I prefer all my patients to have a little bit of pressure support. I want my patients to be in a mode where they can breathe on their own, but I need them to have a little bit of oomph to overcome the ET tube. The next few slides talk about BiPAP. We're going to skip that because you guys should know that by now. Then we talk about pressure regulated volume control. That's a dual mode where you set a volume and the pressure regulates. And I've already talked about that at the beginning of this PowerPoint slide, but you can see the writing there with that PowerPoint. And we talked about pressure support. There's also a mode called volume support. Again, it's a spontaneous mode, meaning your patient better be awake and breathing, because if they're not, they will not get a breath and they could die. So make sure they're awake and breathing. It is to overcome the airway resistance of the ET tube. So that's when we use pressure support and volume support. Either or. Of course, I use pressure because it's better, but some people do prefer volume support. So that finishes up chapter 6. If you have any questions, please let me know.